Assalamu alaikum warahmatullahi wabarakatuh. I am Dr. Rasha Hamdy, Professor of Clinical Oncology. Our topic today is radiotherapy for head and neck cancer. Head and neck cancer or tumors arise from the upper digestive tract, paranasal sinuses, salivary and thyroid gland. As upper digestive tract is lined by mucosa, and the superficial layer of this mucosa is squamous cell, so the most common tumor arising in this region is squamous cell carcinoma. Head and neck region is the region extended from the base of the skull to the root of the neck, and this region is contain many subregions. So we have anteriorly the nose, paranasal sinuses, and behind it nasopharynx, oral cavity, and behind it oropharynx, and in the neck the larynx anterior, and behind it the hypopharynx. Nasopharynx, oropharynx, and hypopharynx is form pharynx. From any of these regions, head and neck carcinoma can be arise. So, oral cavity carcinoma may arise from the rib, floor of the mouth, oral tongue, buccal mucosa, alveolar ridges, hard palate, retromolar trigone. Pharyngeal carcinoma may be arise from the nasopharynx, oropharynx, hypopharynx. Laryngeal carcinoma may be arise from supraglottic, glottic, and subglottic laryngeal regions. And also there is nasal cavity carcinoma or parasinuses carcinoma, may be maxillary, arise from maxillary, ethmoid, frontal, and sphenoid sinuses. Now, what is the predisposing causes of head and neck cancers? The most common predisposing cause is tobacco products. Smoking tobacco, cigarettes, cigars, pipes, chewing tobacco, snuff are the most common cause of head and neck cancer, and it causes cancer field effect. Cancer field effect is a biological process in which large area of organ or tissue are affected by carcinogen. The process arises from exposure to the same carcinogen for a long period. For example, the patient may had laryngeal carcinoma, and after a period may have another cancer like bronchogenic carcinoma, because the upper digestive tract and also the lower respiratory system exposed to the same carcinogen, which is cigarette smoking or tobacco products exposure. Other factors are alcoholic drinks, some chemical substance like asbestos, chromium, nickel, arsenic, also exposure to ionizing radiation in low dose, exposure to some viruses like Epstein-Barr virus, which cause nasopharyngeal carcinoma, human papilloma virus, which cause oropharyngeal carcinoma. The patient with head and neck cancer is present with many symptoms related to the region from which the cancer is arise. If the patient come with nasal or nasopharyngeal carcinoma, may complaining from epistaxis, nasal obstruction, nasal tonation. If the patient come with oral cancer, may present with oral mass, nodule, or ulcer. If the patient complaining from laryngeal carcinoma, may present with hoarseness of voice, and if the patient presented with pharyngeal carcinoma, may be complaining from dysphagia. And also the patient may come with a neck mass. If this symptom is persistent for more than 2 weeks, we must take this complaint seriously, and we must do further investigation. If there is any nodule or mass, we take biopsy, and if it is need endoscope, so we may take endoscopic biopsy from pharyngeal or laryngeal lesion. If this biopsy is proved cancer, so the case must be discussed by a multidisciplinary team. Multidisciplinary team is consist of many specialists, radiologist and pathologist, surgeon and reconstruction team, radiation oncologist, medical oncologist for chemotherapy and target therapy, support personnel for dental, speech, nutritional, psychosocial, and socioeconomic care. Multidisciplinary board is held and discuss the case and put the plan of the treatment according to many factors: patient factor and tumor factor. Patient factor include age of the patient, comorbidity, condition of the patient. If the patient, for example, complaining from hepatic disease or renal disease, so we must avoid some type of chemotherapy, and we must need adjustment of the dose of some chemotherapy. Performance status is a very important factor, and in cancer patient we follow the ECOG performance status. This performance status is depend on the activity of the patient. ECOG 0, the patient is asymptomatic and fully active, can do the outdoor work and the housework and also self-care. ECOG 1, the patient becomes symptomatic, can do light outdoor work and light housework and of course self-care. ECOG 2, the patient is symptomatic, stay in bed less than 50% of the day and can perform self-care. ECOG 3, symptomatic, and the patient is stay in bed more than 50% of the day and self-care with help or capable of only limited self-care. ECOG 4, the patient is bedbound and need completely self-care. ECOG 5, death. Other factor is factor related to the tumor, and the most common factor is TNM classification: T for tumor size, N for nodal status, M for metastasis. For example, staging of timely cancer. As regard tumor size, T1 is tumor less than 2 cm, T2 is tumor from 2 cm but not more than 4 cm, T3 tumor more than 4 cm, T4 if the tumor invade the surround structure, T4A if the tumor invade skin, mandible, T4B if the tumor invades the base of the skull or carotid artery. As regard lymph node, N1 if there is a single clinically positive ipsilateral node less than 3 cm, N2 single clinically positive ipsilateral node 3 to 6 cm or multiple ipsilateral node with all less than 6 cm or bilateral or contralateral node with none greater than 6 cm, N3 node more than 6 centimeter, either single or multiple. As regard distant metastasis, M0 no distant metastasis, M1 distant metastasis is present. Staging: stage 1 T1 N0 M0, stage 2 T2 N0 M0, stage 3 either T3 or N1, stage 4 either T4 or N2 or N3 or M1. When we speak about head and neck treatment, we must keep in mind two factors. The first one is the function and the cosmetic issues of these organs. Second one is the aim of the treatment. It is curative or palliative. If it is curative, so we must preserve the organ as much as possible. If we have early stage 1 and 2, we can reach to this goal by surgery alone or radiation alone. Surgery is just remove the tumor with safety margin around it and the draining lymph node. But if the case is advanced, so we can combine multiple modality to reach the curative goal, either chemoradiation or surgery followed by radiation and chemotherapy. But if the aim is palliative, in metastatic stage 4 case, we can give just palliative radiation or palliative chemotherapy. Now, what is the role of radiotherapy in head and neck cancer? Actually, we can give radiotherapy either definitive radiotherapy or neoadjuvant or adjuvant radiotherapy or palliative radiotherapy. Definitive radiotherapy, with or without chemotherapy, it means that the main treatment of the cancer is radiation. And the advantage of this approach, it allows for organ preservation in some cases. And organ preservation is main issue to preserve cosmetic and function of the organ. Adjuvant radiotherapy is given after surgical removal of all tumor, and if postoperative pathology revealed high-risk patient indicated to adjuvant radiotherapy with or without chemotherapy, like advanced T3, T4, like positive lymph node, lymphovascular invasion, perineural invasion. In this case, we give postoperative adjuvant radiotherapy with or without chemotherapy, and the advantage of this approach to decrease the chance of recurrence. As regard the neoadjuvant radiotherapy, with or without chemotherapy, we give this treatment before surgery, and the aim of that to shrink the tumor for better surgery and allow determining the response and the sensitivity of the tumor to the given chemotherapy and radiation. And we can, if it is high sensitive for this treatment, we can give it again if recurrence occur. We also can give palliative radiotherapy if the patient has metastatic disease and this metastasis is symptomatic, like painful bone metastasis or like bleeding from advanced tumor. We can give palliative radiotherapy to control these symptoms. To deliver radiotherapy, we have two techniques: standard external beam radiotherapy, or the other name is teletherapy. In this machine, we use radioactive isotope or artificial radiation, and there is a distance between the tumor and the source of radiotherapy, so it called teletherapy or external beam radiotherapy. The other form of technique of deliver radiotherapy is brachytherapy. This is a form of radiation in which the source of radiation or the radioactive isotope is embedded or implanted inside the tumor tissue. As external beam radiotherapy is a type of radiation which used in our department. So, what is the step of planning a patient for radiotherapy, for external beam radiotherapy? First step is simulation. Simulation and immobilize the patient in the treatment position and fix the head of the patient by using face mask to hold the head and allow targeting mark to be painted on the mask. At simulating room, while the patient on simulating table immobilized in the same treatment position, CT cuts is obtained and these CT images are imported into treatment planning computer. At planning room, we start to delineate organ at risk as well as the target, which include the primary tumor and the lymph node. In this image, this is a case of laryngeal carcinoma. We delineate organ at risk. In this image, the organ at risk are parotid gland, spinal cord, apex of the lung, and we also delineate the primary tumor and the draining lymph node. After that, we reconstruct these CT cuts to create a computer reconstruction of the patient and the cancer. After that, radiation zone is designed to cover the cancer and the nodes and avoid normal structure as much as possible. And now we can design the field arrangement and finish the planning. As regards dose and fractionation of radiotherapy, definitive radiotherapy dose is 73 to the primary tumor and the gross lymph node. Uninvolved lymph node station will receive from 44 to 64 gray. We deliver radiation in conventional fractionation, that means 2 gray per fraction daily for 5 days from Saturday to Wednesday in 7 weeks. That means 1000 per week for 7 weeks. As regards post-operative or adjuvant radiotherapy, we preferred interval between the resection and the post-operative radiotherapy about 6 weeks to allow a complete healing of the wound. The dose to the tumor bed is ranging from 60 to 66 gray by conventional fractionation, and to the neck to involved nodal station ranging from 60 to 66 gray also, and uninvolved node ranging from 44 to 64 gray. As we mentioned before, we delineate the target volume and also we delineate the organ at risk to decrease the side effect of these of radiation on this organ. But there is some structure may be affected by radiation and we can't avoid this affection, like skin, teeth, mucosa, and salivary gland. Side effect of radiotherapy is either acute or late side effects. Acute side effects is during radiotherapy and short period after it, while late side effects occur after 3 months of radiation. Acute side effects include radiation dermatitis due to the effect of radiation on the skin, acute xerostomia and dry mouth due to the effect of radiation on salivary gland, change in taste, mucositis, and the mucositis is the most common side effect and the most common problem during radiation and may cause a stoppage of radiation, so it is the most critical side effect. Also there is dental problem and dental caries and may acute laryngitis due to the acute effect of radiation on the larynx. This image shows acute radiation dermatitis. There is erythema, dry desquamation, and also with desquamation. This is another image for patient complaining of radiation dermatitis, acute radiation dermatitis, at last day of radiation and 2 months later, with complete healing of this reaction. This image is image of a patient during radiotherapy with acute mucositis. As regard late side effect of radiation, which occur 3 months later after finishing of radiotherapy, it includes chronic xerostomia and dryness of the mouth become a permanent problem, and this problem depending on the volume of salivary gland inside the treatment field. Also, teeth decay may become a chronic problem and must be treated well to avoid osteonecrosis of the jaw. Long-term problem with swallowing due to fibrosis of the upper part of esophagus, which included in the treatment field. Persistent hoarseness of the voice due to chronic laryngitis. Hypothyroidism due to including the thyroid gland in the treatment field. I hope this lecture to be clear, and thank you.